Welcome to this book webinar sponsored by the UCLA Center for Health Policy Research. I am Mark Peterson, Professor of Public Policy, Political Science, and Law at the UCLA Luskin School of Public Affairs and a Senior Fellow at the Center. As a land-grant institution, we would first like to acknowledge the Gabrielino Tongva peoples as traditional land caretakers of Tavangar, that is, the Los Angeles Basin and South Channel Islands. I couldn't be more delighted hosting this talk and conversation with Colleen Grogan on her literally magisterial and granularly analytical new book, Grow and Hide, The History of America's Healthcare State, published by Oxford University Press last year. It's real, you see it on the screen, but it's really an incredibly significant and mighty volume. Colleen and I met 3 decades ago as young fellow travelers in the then nascent community of health politics and policy scholars in the American Political Science Association, which is now fully embodied as the organized section on health politics and policy with hundreds of members, and which Colleen would later lead. From those days as an assistant professor at Yale University, Colleen is now the Deborah R. and Edgar D. Janata University Professor at the Crown School of Social Work, Policy, and Practice at the University of Chicago. One of the nation's leading experts on the Medicaid program and national and state healthcare policymaking in general, among other health and healthcare issues, Colleen has been a 2-term editor of the Journal of Health Politics, Policy, and Law, along with other significant editorial roles, and has performed various leadership roles in the field of health politics and policy, as well as on the campus of the University of Chicago. She has earned much acclaim, evident in being elected to the National Academy of Social Insurance, inducted as a fellow of the American Academy of Social Work and Social Welfare, selected for a Fulbright, and a recipient of a Robert Wood Johnson Foundation Investigator Award in Health Policy Research. Much more could be said, but let's get to this fascinating book. As we do, I'll just add that this is especially fitting to have Colleen discuss the themes of her book, Grow and Hide, at the Center for Health Policy Research, which was founded by the late E. Richard Brown, author of the 1979 study, Rockefeller Medicine Men, Medicine and Capitalism in America. Colleen will provide an overview of Grow and Hide for the next 20 to 25 minutes or so, and then she and I will spend some time in conversation before we open things up for questions from all of you. And just as a reminder, please submit questions along the way into the Q&A tab on the Zoom screen. So with that, Colleen, the floor, or should I say the screen, is yours.
Thank you so much, Mark, for that introduction. That was really just so sweet, and brings back lots of memories of the times that we spent together in the early 90s even. And thanks, Tiffany, for all your work planning this event, and thanks to all of you on this webinar for attending and for your interest in the book. As Mark said, I'll just be talking for about 20 to 25 minutes. So it's a thick book, as Mark also showed. So I'm really just going to give you an overview of the main argument and the arc of the book. And then in Q&A and in our conversation, I hope we can dig more deeply into different parts of the book. Before I do that, though, I wanted to start with a quote, as Mark said, also from the late E. Richard Brown, who, of course, was a national public health leader, but also played such an important role at UCLA. And the reason I want to start with this is that when Mark told me this about Rick Brown and his connection to UCLA, which of course I knew he was on the faculty there, but I said, oh, Rockefeller Medicine Men. The book was very formative in me writing Grow and Hide. I remember reading that book as I was starting my research and feeling like, wow, he's really saying what I'm finding. And so I just want to start with a quote from him. It's the introductory paragraph of the book. And he writes, the crisis in today's healthcare system is deeply rooted in the interwoven history of modern medicine and corporate capitalism. The major groups and forces that shaped the medical system sowed the seeds of the crisis we now face. The medical profession and other medical interest groups each tried to make medicine serve their own narrow economic and social interests. Foundations and other corporate class institutions insisted that medicine serve the needs of their corporate capitalist society. The dialectic of their common efforts and their clashes and the economic and political forces set in motion by their actions shaped the system as it grew. Out of this history emerged a medical system that poorly serves the society's health needs. Now, that is as true today, unfortunately, as it was in 1979. And the findings in my book completely resonate with this argument. I build on Rick's book by not only revealing how medical interest groups eventually became aligned with the capital markets really significantly in the post-1979, starting in the 1980s, but then also really focus on the role of the state to build up the healthcare system. So let me turn to that now. The book is called Grow and Hide. So what exactly is Grow and Hide? Well, quite simply, it's a phenomenon where we have substantial government funding of the US healthcare system, up to 70% of national health expenditures today, but that funding is largely hidden from view. So it's hidden because of the way we structure the US healthcare system, but it's also due to intentional public discourse, which perpetuates a myth that we have a predominantly private healthcare system with relatively little government involvement. In the book, I open with examples from Obama and Trump, and I do that intentionally to show how the discourse of a private healthcare system and elite support for this American myth runs across the political spectrum. But you can find examples of this everywhere. And most importantly, it is perpetuated by private actors who receive substantial government subsidies. Now, most Americans know government is involved in healthcare today, and all of you on this webinar know that. They point to public insurance, Medicare and Medicaid, as the main drivers of government spending. And of course, they are main drivers today, but government subsidies extend far beyond these two programs and did not start with the enactment of these two programs in 1965. So I devote the first two parts of the book, over 200 pages, to detailing how and why government spending increased before 1965, starting with the first municipal health department in 1866. So why did growth occur? If Americans have always believed in minimal government, why did government investment grow? Government investing in public health began due to scientific evidence that sanitation, clean streets, clean water, was the answer to fight epidemic diseases such as cholera. And there was support from the American Medical Association at this time. Today, we think of divisions between physicians in the healthcare system and public health. But it didn't start out that way. Physician scientists at that time ran the AMA, and they were also the leaders of public health. So they supported expansions in public health, as well as there was a lot of support from business and citizen groups. And as a result, the municipal health department that was first established in New York City expanded quite rapidly across the country. It then expanded to, we had the development of state health departments, and those expanded across all of the states. And eventually we also get the Federal Public Health Service established in 1912. But this growth happened alongside patronage politics, which really influenced how growth occurred. So one thing to clarify is that there were boards of health before establishing the first municipal department of health in New York City in 1866, but these boards were perfect examples of patronage plum. So a city inspector connected to the party machine ran the health board. And the city inspector would hire staff with ties to the party and with no scientific expertise. So the municipal health department was the first scientific agency where sanitarians ran the agency and hired scientists and other trained personnel. But public health leaders, understandably so, given the height of patronage politics, didn't really trust government. And they wanted a separation between their scientific agencies, what they were trying to establish as scientific agencies, from patronage politics. And so another thing that they did was they would contract out with the voluntary sector a number of their programs. And they did this in part to keep government at arm's length. And this rhetoric of the voluntary sector being private and not government starts very early on in this period. So you have this structure of federalism and contracting out with the voluntary sector from the very beginning of building the system. So if there was so much support for growth, why was it hidden? What happened? So the field of public health changed from sanitation to communicable disease. Whereas sanitation was clearly distinct from providing individual patient care, addressing communicable diseases like tuberculosis or venereal disease were not. They needed to provide treatment to address these diseases. And when that happened, private practice physicians threatened and fought against public health expansions. They were worried that they were moving into their turf, and they were in many ways moving into their turf. They dominated, these private practice physicians dominated county and state medical societies, and they fought against the national AMAs. Support for public health and state involvement. And eventually they won support of local politicians to limit growth, but they were not against all expansion. So what I add to some of this history about public health is people say, oh, this is when the real divide of healthcare and public health started. And that's true, but they kind of, what's been missed is what was their support for public health to continue doing, what was called the public healthcare state and government's involvement. And there was support in four main areas. So there was support for building the healthcare system, hospitals and clinics. There was support for workforce development. There was support for prevention and population health, or what they also called the difficult to treat cases. So private practice physicians said, you take care of TB, polio, VD, we don't know how to deal with that. And then care for the indigent. Now, what's important about those areas of support is that, especially around prevention and care for the indigent, is that these areas are very ambiguous. So VD clinics, for example, were framed as prevention while actually providing a lot of treatment. And where to draw the line between the poor and non-poor, or the medically needy and non-needy, has always been ambiguous. It was ambiguous, it's ambiguous today, and it was ambiguous back then. And as a result, this allowed actors to strategically frame growth as squarely within the realm of prevention, or squarely kind of only taking care of the needy while actually doing much more. So in the remainder of part one of the book, I show how the system continued to grow, so much so that by the time we get to the 1930s, the New Deal period, it was not unreasonable to argue, as many did, for what they called state medicine, or what also became known as the National Health Program. So when historians have looked at the New Deal, they have concluded that we did nothing regarding healthcare reform. And it is true that we rejected compulsory health insurance. But in the New Deal, we passed the Public Health Acts, which eventually led to the National Health Program. And this program included four main components. So infrastructure building, workforce development, care for the poor and indigent, and public health spending. Now, in most documents that talked about this national health program, it also included compulsory health insurance, which is why I have it listed here on the screen as number 5. And repeatedly, as we know well today, compulsory health insurance was always rejected, but these first 4 components were not, and they were in the Public Health Acts, and there was funding for them in many other acts and at many levels of government throughout this post-New Deal period. And so remember, these 4 components were also the same areas of support that private practice physicians and many others supported back in the 1910s. So that never changed. And so, for example, we see hospitals continue to grow over this period, and government was financing half of the construction costs to build hospitals. So under the New Deal Public Health Acts, they said, we are just continuing to do what we've always been doing, what we're already doing. And that was true. And there was no controversy over these public health provisions, and they just sailed through. And we continued, as I said, to invest in all 4. What happens is there was a period of time from 1935 to 1945 when leaders from many different sectors, but public health leaders, those support of the Social Security, even business, some people from business, were in support of government growing and rationalizing the healthcare system, and they were trying to reveal government's extensive role. So you get this period of what I call kind of grow and reveal. So even though I kind of track this long history of grow and hide, there is this really important period of attempts to grow and reveal, and you see it here on the screen, a quote from Thomas Parran, who was the Surgeon General appointed by Roosevelt. So he makes a statement right after the public health provisions are passed in Social Security in 1935. And, he says one of the most significant events in the history of public health was when when the Social Security program was passed. Most people think of Social Security in terms of unemployment, but for the first time, we get a start on a national program. That's the National Health Program that many people referred to in exactly those terms. And he's setting the stage for that to protect and promote the health of the people. So really trying to signal to people, this is much more than you think. So the reveal part, right? Before they're trying to kind of hide, oh no, it's just prevention, it's just the truly needy. But here, no, they're putting it out there that we're really building something much more. And I'll give one more example. I have many more in the book, but this is from Edwin Whitty, who's been called the father of the Social Security program. He was the chair of the Committee on Economic Security, which essentially designed the Social Security Act. And he said to a group of healthcare leaders and concerned citizens in Wisconsin in 1938, but he was kind of going around the country making similar speeches. And he's talking about the National Health Program, and says it's a proposal for greatly increased federal aid to the states for state and local health services. But even by that time, you have the AMA and a few other actors trying to associate that with socialized medicine, right? So he says, well, many people apply the term socialized medicine to every development which they don't like. But what is this thing, socialized medicine? Well, okay, if it's medical care and other health services which are provided at public expense, that is from tax funds, it includes the long-established federal, state, and local public health services. And so socialized medicine is not a bugbear, but a very familiar phenomenon. Socialized medicine has long constituted a very considerable part of the total health services rendered in the United States. And so I just love this quote because that's the real reveal, right? Like we're already doing this. We're already paying for it. Let's just be honest, and then we can build and rationalize, right? That was their effort. But Ironically, even by 1940 or 38, when he's making these claims, the government-funded system had spread in such a hidden way that it was difficult to make it transparent, even when actively trying. So these attempts to reveal, don't succeed. And so the way that the system is so significantly hidden is, as I said, through three main structural features that explain grow and hide. So the use of the federal structure, delegating authority to the voluntary sector, and institutional fragmentation. Now, federalism, it makes it easy to grow because you can leverage funds from other sources, such as state government can leverage federal funds through grant and aid mechanisms. And other things. But it also makes it easy to hide the total expenditure growth because you just focus on the expenditures at the state level, right? So you get this phenomenon of grow and hide structurally through federalism. You also get it through contracting out. Contracting makes it easy to grow because it's framed as investing in the private sector, but then hides the role of public financing behind it. But what do I mean by institutional fragmentation? What is that? It's a process of moving responsibilities out of health departments to other agencies. So why would we do that? Why would public health leaders be in favor of that? The first reason is back to patronage politics. So there was a desire to keep health departments as scientific agencies. And as sanitation, for example, became more routinized, this is just one example, you no longer needed skilled workers with scientific knowledge. And it fell prey to patronage politics, to garbage collection became plum jobs again. So they moved sanitation to separate agencies to keep health departments as purely scientific agencies. The second reason was purely kind of political and strategic. A smaller budget within public health made it easier to argue for more funding. So they were in a constant process of reifying what an ideal public health department should look like. And so, for example, hospitals were moved to a separate budget, and separate government commissions would oversee hospital development. It was all government funding, but it was this process of institutional fragmentation, so that by 1940, 20 different state agencies on average were doing health work. And the same phenomenon happened at the local and federal level. So you see this, health work distributed across many, many agencies at all levels of government. So trying to reveal government's role failed in part because the structure was already so complicated, it made it difficult to see, as the boxes in blue and as I just described happened, but also because delegating public money to private actors allowed the private sector to take control of discourse. This happened because policies create new politics, kind of an old idea now in political science. And new political actors have incentives to shape the discourse. So all this infrastructure building that I just described created a powerful hospital industry with vested interests in this now government-funded system. So even though they were funded by government, they turn against government. So ironically, they use much of the same language that public health leaders who distrusted government in the progressive era used. It's government's corrupt and bad, and we need to contract out, right? So the discourse begins to shift. And when the political climate changed in the post-World War II period, with the rise of McCarthyism and a substantial downsizing of federal government staff, especially in the public health service and the Social Security offices, this discourse really shifts, and the narrative is dominated by the voluntary sector. The nonprofit hospitals in particular, but also voluntary disease-based organizations, and I cover this in chapters 5 and 6. So when Truman proposes the national health insurance, a truly compulsory national universal system, it doesn't even make it out of committee. And there's been whole books written about this. It has more to do with just a major shift in the discourse. But I do argue in the book that this shift to the voluntary sector is really significant. And that the American Hospital Association argued that the voluntary sector is more democratic than government itself. So this demonization of government really is, you see it in the early period, but it really begins to take hold quite significantly in this time period. They argue it's more efficient and offers more freedom and choice than government. So they argue, again, the National Health Program, we have these four components: continued investment. The AHA argues persuasively to pass the Hill-Burton Act, which is more hospital infrastructure building. And they're quite successful at getting that bill passed. So they fight for more government funding for construction, but with few strings attached. So Hill-Burton is presented as an alternative to national health insurance. They argue that if we provide infrastructure, American citizens will have access to care. But importantly, nothing was written in that act that ever actually provided people legal rights to care. So it could have been something like a national health service that we have in Britain, but of course it was not. At the same time, hospital costs kept rising. And this wasn't a new concern. We had the Committee on Medical Costs back in the 1920s. But that concern about rising healthcare costs never goes away. And so the American Hospital Association had to convince the American public that the voluntary hospital system was in their best interest. And so the AHA conducted a major public relations campaign, kind of tell your hospital's story, which I cover in chapter 5. As the quote suggests, they say, don't apologize for costs. Costs permit offering the kind of care the public wants. And you got to exploit these exciting and dramatic results, and let them know that you have to have rising costs to get the quality that we need. This story, which this is not on the screen, but the story also told the public that it is moral to pursue aggressive collections, and argued that patients taking on medical debt is morally justified. So we get these arguments starting actually in this very early period. And of course, we well know that medical debt, aggressive collections, is still with us today. The other thing they did is develop pamphlets that were distributed to every voluntary hospital in the country, and I have evidence in the book that they distributed this quite substantially to communities. And what was most important about the pamphlet is it blamed the government for low quality of care. So again, this demonization of government. If it's high cost, it's because you need quality. If there's any problems, it's government's fault. So before we passed Medicare and Medicaid in 1965, the state is playing a substantial role in financing the US healthcare system, and yet its role is completely hidden from view. And control of the narrative has shifted to the private sector. And most significantly, I think the hospital sector, but of course, AMA is playing a big role there as well. So why does this matter? What are the major consequences of grow and hide? And I have the major 3 on the screen here. And the first is fragmentation and a complete failure of healthcare planning. And that I cover in chapter 7. Even though public health and health reform leaders tried to rationalize the healthcare system in a series of legislative acts in the late 1960s and 1970s, the logics of grow and hide, a seriously complicated system with private sector dominance, leads to a complete failure of healthcare planning. And we have never had any true regulatory planning of the delivery system since that time. The second consequences profiteering or, the financial industry's takeover of the system. And I cover that in chapter 8. In the 1980s, with the shift to the competitive approach, grow and hide increases even more, especially in the area of subsidizing hospital construction. But most importantly, we shift from subsidizing construction through direct government grants to subsidizing tax-exempt bonds and Medicare reimbursing hospitals for interest and depreciation. And this allowed for a massive shift towards reliance on the capital markets for debt financing of hospital construction, but also many other healthcare facilities. And it creates even more of a bifurcation between hospitals into what has been called the have hospitals, who focus their services on private insurance, largely white, middle class, and affluent communities to secure high credit ratings in bond markets, and the have-not hospitals, who serve the poor and low income and often largely communities of color, and who have difficulty securing capital due to low credit ratings. This opened the door to the financial industry's massive interest in investing in the healthcare system, and I would argue opened the door to private equity investment, which we see today in almost every sector of our healthcare system. And finally, the third major consequence is inequality and what I call the conspicuous healthcare safety net. I cover that in chapter 9. And what I mean by that is, although we have growing inequality, and we've had inequality for a long time, the public discourse focuses on the problem of public expenditures for the poor, while hiding the subsidies, quite substantial subsidies, to the middle and upper classes. So in the last chapter of the book, chapter 10, I show how the ACA embraces grow and hide. And in fact, the ACA is the biggest grow and hide of all. Massive public investment with almost complete reliance on the private sector. Federalism is central. Institutional fragmentation is on steroids. And discursive strategies that hide the government's role is commonplace. So Medicaid is not Medicaid. We have Indiana's Healthy Indiana Plan. Kentucky's ACA Marketplace is Kentucky Connect, et cetera. So I think the book, Grow and Hide, there are 5 main themes that Grow and Hide illuminates, but rather than go into each of these themes, I'll stop there and turn it over to Mark to open up a conversation.
Thank you, Colleen. That was really a terrific overview of a very long and highly detailed book. I think much of your story, many of us have in the short story version, and you give us the truly deep dive into what must have been a massive effort of data and information and documentary collection. So thank you very much. I'd like to take some big themes here and start with exploring even further the meaning of hide and grow and hide in the current context. So let's get to the situation of today that you've already alluded to in a way, and parts along the way of the reveal. When I look at things, I see Medicare as the second largest single payer system among democratic countries. As you've mentioned, Medicare and Medicaid are already huge in context. There are 150 million people covered by them. Throw in veterans health and children's health that's not part of Medicaid, and military TRICARE. And as one of the audience members said, we can throw in community health centers too in some ways. We're talking about over 170 million people, over half of the population in the United States, on direct public financing. Mm-hmm. And as you mentioned, 70% of all dollars spent on personal health care are public. And even more interesting, I think Sherry Gleed brought this up in an op-ed a while ago. If you look at public per capita spending for healthcare, no one spends more than the United States does, even all those countries with universal coverage. So what I want to ask, I'm going to lay out 3 parts of this, and you can take it wherever you want. One, is this a sign of the success of the grow and hide strategy, given the nature of American politics and federalism and fragmentation? Does this also now, this obviousness now change the politics? It's kind of like being 7 or 8 months pregnant. You can no longer hide that this is actually going on. Does that change the politics and the viability of this strategy? And what's the signaling now that Republicans for the last many years have been willing to take on directly the public side and try to attack it and challenge it, from Medicare to Medicaid to the ACA to public health institutions following the COVID pandemic? So how do you wrap up this grow and hide in the context of where we are right now?
Yeah. Oh my God. Thank you so much for those questions. Perfect. So I'll just start with the first one. Sort of like, is this an indication of this success of grow and hide, given the growth, right? Like we do have massive growth of public health expenditures and public programs. And so, yes, I mean, on the one hand, it is a success if part of the strategy was exactly to try to grow government's involvement in the healthcare system while at the same time hiding it from the American public. And so, yes, that strategy has been amazingly successful. Using the term success, though, is always like, given my concerns about the major consequences of grow and hide, I have trouble calling it a success, right? Because I think the part that we've this has been a strategy around Medicaid for quite a while, right? Like starting with the Children's Health Insurance Plan in the mid-90s, states expanded coverage to children and working families. And the strategy was, well, we have to change the name of Medicaid because working class families would never want to sign up for Medicaid. That's too stigmatizing, right? So we need to change it to, Husky Care in Connecticut or Badger Care in Wisconsin, and then they'll think it's private insurance. We'll contract out with managed care plans, right? And so that strategy again is sort of like it's still a public insurance program, but we'll present it as something other than that. So very successful. Take-up was enormous, but that's also created lots of difficulty in trying to create a cross-program constituency mobilization for Medicaid. So that's just one example of how, yes, successful at growth, but not successful at creating a political constituency around that growth in ways that could improve the quality of care in the Medicaid program and improve access to care, because those are still serious problems in Medicaid. Also, so kind of moving to your second question, which is related to what I was just talking about the politics, is it possible to still hide? And yes and no, right? That's the inequality part, the last sort of major consequence that I talked about, where I really like that you point out that Republicans, especially since Obamacare, have really been attacking, the Medicaid expansion and, a little bit Medicare, but not really, right? Because they're not that's sort of our middle class entitlement program that doesn't work politically very well for them, but certainly attacking.
Although they did try in 1995.
Right. They tried. And I think maybe they learned something from that. Right. But what I think is so important is, and again, that's exactly my argument, is they do attack, what they reveal is public insurance for the poor. So the part that Republicans don't go after all that much, right, is like Medicaid's coverage of nursing homes. They tried a little bit in the early 2000s, but that also didn't go over very well, right? Like most middle-class people they need help covering their parents in nursing homes. And a lot of middle-class families do rely on Medicaid actually to cover the cost of nursing homes. So it's interesting, even within Medicaid, what Republicans target are the, groups that they can frame as undeserving, right? And they've been very strategic to say, it's the group that no longer deserving. It's, men, like in the Medicaid expansion, right? Single men should be working, and they're not deserving of public dollars. So we're back to these like very old arguments in a way that at one point I thought maybe we would be able to move beyond, but in 2000s, you have Republicans kind of hearkening back to the 1965 arguments around Medicaid, that Medicaid should only be attached to cash assistance, and just be for the truly needy. So yes, they attack the public part of the grow and hide, but just a small little fraction of it, actually, because it turns out that most Americans, they're really supportive of the majority of public subsidies for our healthcare system. Now, the problem, of course, is that there should be more open reveal and transparency of how much we are spending, because we don't spend it in good ways at all, right? It's incredibly unequal, it's incredibly wasteful, and so much goes to the profit-making part of the system. And that's just not getting really, it is a little bit. The growth in private equity, I think, there's been a number of exposés, and the American public does not like the pharmaceutical company. But when you then ask them, okay, do you want Medicare price setting to try to clamp down on them? The public is not so clear about that, right? So it's tricky, yeah.
Let's I love the themes that you're developing here out of the politics and the impact of the grow and hide and what that translates as in both expansion and also still serious problems with the system. I want to, for a moment, take your part 3 on the consequences of grow and hide and bring in a complementary lens to that. As you know, our colleague Jacob Hacker in 1995 published a book, The Divided Welfare State. It was kind of part of a whole compendium of books about the shadow welfare state, the hidden welfare state, and all those things. But one of the things that Jacob talked about is when you take the after-tax public and private social welfare expenditures in the United States actually spend a comparable percentage of GDP on social welfare programs of the major OECD countries that are always thought to be the social welfare leaders, if you will. But he raises serious implications about that structure, just as you do in Grow and Hide. And he has 3 things in particular that he highlights, and I'd be curious to have you reflect on Grow and Hide through this lens, because it fits with just what you were talking about. One is he talks about this approach really creates all kinds of barriers to policy change, because now you have all these larger numbers of players out there who have to play a role, health benefit managers in corporations and whoever else it might be outside of the state. A second thing is it's difficult to even know whom to hold accountable. When we're thinking about healthcare, do I hold accountable UCLA, the University of California, the health plan, the state of California? It's just who really is holding responsibility. I always remember people telling me, in Canada, when there's a problem, it goes to the floor of the parliament of each province. And we don't have that here. And the third is this, and you've alluded to this, it's really, in terms of the equity issue, this really perverse distribution of public resources. The taxpayer of the United States is paying more for my healthcare than is paying for the healthcare of the people who attend to the grounds of UCLA or who clean the building in the evening after I go. And that just strikes us as in many ways truly perverse. So using those lenses, how would you, does it still resonate all these years later, even after the Medicare Modernization Act and the ACA and the fact that they have embedded, as you say, these grow and hide features? Where are we with all that?
Yeah. My super short answer is all 3 still apply, and that, it's interesting because, Jacob really focused on private provision, that which happens through the tax system. And part of what I was trying to bring out is like a lot of it was happening through direct public expenditures, and so it's even bigger. In some ways, what I was trying to say is even when we do it through direct public expenditures, there's still this a really important way in which it continues to grow and yet hide. You wouldn't think we would be able to hide the direct public expenditure side. So I think that's part of what I'm trying to add to like the focus on, he was on the healthcare side anyway, he was primarily focused on like the tax exemptions to private health insurance, right? Which is super important. And I almost barely cover that in the book because he and others do such a good job of like, what's been done in that side. So yes, like barriers to policy change. It's very interesting because although we had that period post New Deal of reveal, of grow and reveal, there was another kind of very, very short period post Medicare that I didn't really have a chance to get into, where there were similar efforts to kind of reveal, I think, because there was hope that, you know, Medicare was going to be our stepping stone to national health insurance. And that's where a lot of those planning acts came out of, right? It was like, oh, well, we can finally focus on rationalizing the system because it's clear that we're going to have a national health insurance system, and government is playing a role, and government therefore should also play a significant role in planning that system, right? And but again, you know, absolutely, the hospital industry fought for voluntary planning, was successful in getting voluntary planning, which means sort of, you know, lots of discussions about planning with no real teeth to ever enact something to change our delivery system. But then reified what those planning acts were to be very strict regulation, right? So part of our difficulty, and you know, Jacob gets at this as well, but is the power of these private actors, and in concert with certain political actors, right? But to frame the problem, right? And to say that to say that public expenditures are used very, very inefficiently, and government is demonized. So not only is it hard to change because it's hard to know who to hold accountable, that problem, right? I think now people know, like when they look at pharmaceuticals, they blame the pharmaceutical companies. But the problem is that, and they know even when you tell them, so Eric Potashnik and his colleague just did a recent experiment related to the Medicare pricing, which I thought was so interesting because what they found was that the experiment was to tell them about the amount to which government subsidizes the development of our drugs, right? And like the top 10 drugs are primarily financed, the development of those drugs, from government funding. And so they thought, well, if you just tell the American public, you've already paid for this. Like, this isn't this argument that private sector did all this R&D. That's not true. So even when you tell them in the experiment and they believe what you're telling them, they will say, well, I don't like pharma, but I'm not supportive of, I don't know about this price setting because it's government. I think I'll talk to my individual physician, right? And so we have this, the other way that I try to reveal and grow and hide, right, is how connected that process was also to the demonization of government. So that, I think, that's just a major hurdle for us with thinking about policy change and who to hold accountable, because government should be given the you know, the power it needs to hold these private actors accountable, but we're just really reluctant to give government all that much power. And so it's related to this problem of kind of you know, this demonization of government is very self-reinforcing, right? And that we, you know, it just perpetuates itself and creates difficulties for change.
Along those lines, before we turn to the audience, I want to get one more thing in here, and you alluded to it in your discussion, and it's very nice coverage in the book, and that is the kind of race rhetorically. Do you need to write a book now or a second volume, which is the reverse of Grow and Hide, which is to look at what's happened on the private sector side, the for-profit side? So, you know, since the 1990s, there's been this fundamental shift in just regular private insurance coverage, from nonprofit plans to now overwhelmingly for-profit commercial insurance plans. We still have nonprofit hospitals, quote unquote nonprofit hospitals, but they behave more and more and more like their for-profit counterparts, both how they pay their administrators, how they run, what they claim that they're doing, and yet they're getting these tax protections. And as you write about very nicely, there was this, and started to be this real focus on the role of private capital in the healthcare system. Now, explicitly, more specifically, private equity purchasing up all these entities in the healthcare world. So do we need Grow and Hide number 2, which is what's happening on the commercial side?
You know, um, so my response to this, I really see it as, and you know, again, chapter 8, and I hope, you
Right.
know, even I kind of bring it back, bring the role of capital and private equity back into chapter 10 and the ACA. And to me, it's just, you know, it very much follows from the grow and hide regime, right? And so even though we say, so this is also part of the power of these private actors, right? Is they've led people to believe that, oh, this is commercial and it's for profit, therefore maybe it's the reverse of grow and hide, but really they're still making a good portion of their profits are made off of government subsidies, right? And so it's just, you know, it's still government a predominantly government finance system, but rather than the private sector relying on those older arguments about the voluntary sector, they're now relying on new arguments about you need, and this maybe does demand a new paper, which, but that's my next book is the financialization of health
Yeah.
politics and financialization of health. And what's happening there is they're using the arguments of innovation, disruption, and that the only way you get that, the only way you really disrupt, and in fact, they're financializing health equity, right? So the only way we're truly going to get health equity is if we have a major infusion of private capital investing in these health equity startups, and they're going to disrupt and innovate and be able to finally move us away from this status quo that's so problematic. And the power of that is, you know, it's absolutely 100% true that we have a very dysfunctional healthcare system. And
Mhm.
so it's very difficult to argue against the claim that we need disruption and the claim that we need innovation and the claim that we need more cost effectiveness, right? Like all the things they say are true,
Right.
but you know, now it's sort of the proof is in the pudding. Are their disruption and innovation actually giving us the things we actually want? And I would argue no. And that government can also be, we know from other systems, and we know from our own past that government can provide the capital. You know, we don't need to have the capital markets
Right.
investing in our healthcare system. We can provide the capital investment and then regulations about what we get in return for those capital investments. And the really interesting thing is there are some states actually moving in this direction, especially around pharma, that are just building their own medical, you know, pharmaceutical companies to develop drugs that are in short supply, and they're tired of trying to rely on pharmaceutical companies to provide it, and tired of then having to pay way more than they should. So some states are just saying, forget it, we're going to build the infrastructure and then make it publicly available. And so it is interesting that there might be a moment here where we can see a really radical shift back to you know, direct investment and like National Health Service like building,
Mhm.
which you wouldn't think in this profit-driven system we would be there, but we might. Yeah.
Interesting. Well, I would love to continue this conversation, but I also want to turn to the audience here. We have about some number of questions in the Q&A, so I'm going to turn it over to Tiffany Lopez to help us through that.
Thank you so much, Mark. And thanks to both of you for joining us today and for this incredibly enlightening and passionate conversation. I'm Tiffany Lopes. I'm the Director of Communications at the UCLA Center for Health Policy Research, and I will be going through some of the audience questions. So one of the questions is, are hospital costs truly so complex as to be beyond the public's understanding?
That's such a great question. I love that question. Thank you for that. And Mark, feel free to chime in because I know like you're so knowledgeable about the healthcare system as well and health policy. So you know, on one level, no, right? It should absolutely 100% not be complex. But we've allowed a system of complete lack of transparency so that what the hospital system presents to us is incredibly complex. And so, you know, of course, we have this bill, a transparency bill that says, please, you know, hospitals need to list all of their pricing for a number of different procedures. And even that, you know, I don't know if any of you have had a chance to look at like that list, but it's incredibly, it's way too detailed to be of any use to consumers, really. And it's not readily accessible to consumers, even though it's part of this transparency. I'm sure some of you might have heard this, like NPR does this, the, you know, trying to solve like the healthcare pricing charges problem for people, and it's, you know, it's just crazy. Every week they tell another story about somebody who got, you know, who went to the hospital, thought everything was covered, you know, get a bill for $20,000, and they describe their bill, and it's just maddening, right? And so, no, intellectually, is it super complicated? No, but yes, in reality and how you have to engage with the system, it's unbelievably complicated and shouldn't be. But, you know, our reform was this transparency bill. And unfortunately, I don't think that transparency bill is going to get us where we need to be. So, Mark, I don't know if you want to add anything to that.
That hits it. I mean, there was even one of their stories was a family had the same thing happen to their child in the morning and in the afternoon, and two completely different bills for the same event, same kind of event in the ER.
Yeah.
Thank you both. Are capital markets significant contributors to the disparities of Latino physicians, especially in California, with 6% Latino physician workforce serving a Latino population in California of 40%?
So 6% of Latino physicians serving 40% of Latino patients. Was that the figure
Yes.
that was just given? Okay.
Yes.
You know, I don't know the exact situation in California, but in terms, if it's that the real disparities we see in terms of sort of matching, you know, physician to patient ratios is typically in the healthcare safety net. And so I have no idea. I presume part of that is being mapped onto the healthcare safety net. And yes, so indirectly, the capital markets within our system is very much related to that disproportion. And I just glossed over it in, you know, in my comments, but that's what I try to really lay out in chapter 8, is that the capital markets want to invest, they want to give money to entities that have good credit ratings. And so the way in which entities that want good credit ratings respond to that incentive is to take care of relatively healthy and wealthy communities. And so that begins to create a real disparity, right? Because they get the better credit rating by only taking care of a portion of our population who needs care. And when they get those capital investments, they get a good credit rating, a good interest rate. It allows them to have even better technology and increase the quality of care. Whereas facilities that are taking care of a much more challenging population, not just in terms of all the needs and everything else, have a low credit rating. The capital markets were horrible about their risk, specifically looked at communities of color. If you were a hospital situated in a neighborhood, and most of your patients came from poor neighborhoods, if you had a high Medicaid caseload, you got a low credit rating. And so the capital markets very much made their decisions based on these dynamics, and it's still with us today.
Thank you. So we knew this was going to happen, that we were going to have a bunch of audience questions that we couldn't get to before 1 o'clock, but do you mind staying on for a few more minutes to answer a few more?
Sure. Absolutely. I'd be happy to.
Great. So this is a follow-up to the first question. How do they come up with the prices?
Hospitals? How do hospitals come up with prices? That's the big mystery, to be honest. I mean, you know, there have been, you know, I mean, there was, you know, starting with Medicare, hospitals got a very, very favorable formula for determining how they would charge Medicare. And essentially, the favorable formula was that they got to set the prices. And there was no requirement to send data to the federal government, right? So the federal government, as the payer, might say, you know what, we want to have some confidence that the price you're giving us is related to the costs of care, right? But initially, they just wanted to get Medicare passed, and they made a major accommodation to the physicians and the hospitals, okay? And the way in which the accommodation happened was primarily through the prices, right? The letting the private sector set the prices and allowing the government to be really very much in the dark about what those prices were based on. And it was hugely inflationary. In the 80s, we got more regulations. The Medicare program said, okay, we're going to set prices based on costs. So people, you had these health services researchers started collecting data on hospital costs, and we got DRGs, right? Eventually in the 90s, we get regulations around physician pricing. But this is a struggle to really understand the private sector cost structure. It's proprietary information. And so they're always coming back to the government and saying, you're underpaying us, you're not covering our costs. And it's like, well, okay, show us the data. And they do, but it's coming from them, right? There is no transparency on really what the cost structures are, so that government can make really informed decisions about where to set prices or where to negotiate prices, right? We don't have that. We don't negotiate prices in the US. That, I would argue, has been a major problem for us all along. And now we finally have it in the prescription, setting Medicare prescription drug prices, and we'll see how that goes. I don't know if
I would add
that answered that question.
It's even more complicated in the sense that there are really 4 levels here. There's the actual cost of what the hospital's providing, which, as you say, we can't even really know. There's the price that they announce for that. There's what they actually charge, which varies by the insurance carrier that they've negotiated. And then there's what people actually have to pay, or what the hospitals actually paid in the end, because there's even more negotiation beyond the charge. And the one thing we do know that if you're uninsured, you pay the price,
right?
Because you have no negotiating power,
right?
Which is again another perverse distribution of resources, where the people who have the least coverage pay the most.
Right. Yep. Absolutely. Yeah.
Can the Hyde regime also be viewed as hide the money, hide the profits? And why can't the demonization of government also be viewed as part of the strategy of hiding the money?
Just completely agree with that question. Great question. I mean, and it is absolutely part of the strategy to demonize government, right? And what is kind of puzzling, I think what the person who's asking that question is getting at is, why haven't, liberals or Democrats or people that want to reveal this, why haven't they tried to really hone in on that demonization problem, right? That sort of like, hey, this demonization is strategic, right? And connecting it. I think there could be something to that strategy. That said, if you remember back to the Whitty quote in the New Deal period, he was trying exactly that. Like, you think it's a big bugbear? Well, we already have it, right? And so it's tricky. It goes pretty deep, this distrust of government. And in some ways it's been self-fulfilling, right? That, back to the point I was making earlier, government, especially today, is really misbehaving in many ways, right? Like, and we talk about the role of capital in our healthcare system and private equity, and we would think there'd be a huge debate in Congress about that right now, but there is not. And Democrats, I hate to say it, but they haven't been great about calling out what's happening. Elizabeth Warren, she gets, in my view, A's across the board, but she's a lone wolf out there, trying to really get this on the agenda. I think it's changing because the evidence is growing about some of the harms of the financial industry, but there's a real entanglement of politicians with the financial industry and real reluctance to reveal part of what they're up to, I think.
Thank you. What are some of the states that are building their own infrastructure and bypassing reliance on pharmaceutical companies?
I'm sorry, which states? Was that the question? Which states are doing some of this
Yeah,
building?
what are some of the states? Yeah, some examples.
California. I think it's I have this, I can send this if the questioner wants to reach out to me. California is one. I wrote an op-ed about this, and Massachusetts is the other. And I think there might be one other state that's also, I think Virginia has kind of a new development in this area too, which is kind of interesting.
Thank you. Values are upstream from virtually everything in healthcare, yet while the issues of value is implied, it's not mentioned. What would happen if the issue of values were made the major focus of evaluating and improving healthcare?
Well, that's again, I love these questions. Thank you. You know, it's very interesting, right? Because I think value-based care is everywhere. That's all the talk, and yet, so the question, right? Like in Medicare, the innovation, the program that came out of the ACA, there's been huge investment in that innovation center, and they've really stressed strongly value-based care, right? And there's been a major shift in Medicare Advantage plans to move towards value-based care. I think that's been taken over, right? That's been, there's been a co-optation of value-based care. What it really means today is just, it's capitation. And so I don't think it's necessarily, I really don't think it is guaranteeing value, but that has become a major focus. So I don't know. It's like, I really sympathize with the question. If it could become a major focus, what would that look like? But how do we do that in light of the private sector's ability to take over and co-opt language and say, I'm doing value-based care, when in fact, it's not clear that that's happening?
So the person who asked the question just clarified that they meant values versus value.
Oh, I'm sorry. Yeah, I mean, that's where we need mobilization, right? From the ground up, and just like, yes, we need a system that focuses on what's the moral foundation, and should the, human rights perspective. Absolutely agree. And I think it would go a long way, because people are not happy, but they just can't quite figure out where to turn. And so there has to be mobilization to figure out what's that strategy. And that's got to include a moral framework. Yeah.
We're just going to ask one or two more questions, and then we'll close the session. Do your analyses include the costs and services for mental/behavioral health care, or solely for medical physical health care?
So the growth in the coverage of mental health, in some ways, I think has taken a similar approach. You see grow and hide around behavioral health as well, in part to get populations that have been stigmatized for so long covered. It's very strategic to sort of grow it, but then hide what we're doing. I think the stigma has lessened over time, and there's less need to hide. That said, I think, like the move toward the mental health system, the behavioral health system is become more integrated into the healthcare system, which we've fought for a very long time. So integrated behavioral health is super important. But that then means that we don't have this separate mental health system. We don't have this separate substance use disorder system. Super important. They shouldn't be separate. They should be integrated. But as they become integrated, they're now part of all the dynamics we were just talking about, right? So one of private equity's major moves in the last decade has been acquiring substance use disorder facilities and mental health, and moving in a major way into mental health. And so the role of the market, the role of the private sector, and their this is an area of great interest of mine, because Medicaid plays a really significant role for substance use disorder. People with opiate use disorder, Medicaid covers 40% of the care for people with opiate use disorder. And so a lot of the profits that these private equity firms are making when they acquire treatment facilities for opiate use disorder is off of Medicaid. It's kind of nursing homes all over again, right? Nursing home is all Medicaid money that private equity was making money on. And so when people say, oh, the private sector doesn't care about Medicaid, it's really not true. It's a real misperception. They care a lot, and they're able to make money off of Medicaid dollars. It's definitely, behavioral health is all part of what we're talking about today, for sure.
I would also add,
Thank you.
and this has been known for a very long time, of course, that a large part of what we do on the public sector side in mental health is actually in the prison system. A lot of the mentally ill in our country, those with mental health issues, end up in jail, and it's the only place they're getting any, they're not even getting any treatment, but it's the only place they're housed. And that takes a lot of the issue off of the screen, really hides it in ways that are profoundly disadvantageous.
Absolutely. Absolutely. Yeah.
Just one quick question to wrap it up, and it's about the book. Somebody's interested in learning whether or not you cover topics about long-term care system, private equity for profit, and skilled nursing crisis.
Just a tiny bit in the book. I do cover that in chapter 8, because when private equity moved into the healthcare system, one of their first moves was nursing homes. And so I kind of cover that evidence. I think in my more recent work, where I'm looking at financialization in healthcare, I do, think about nursing homes as a case. And there's so much to say about that. The one comment I would make is that because of the lack of transparency, the lack of disclosure laws on and over private equity and these private investments, there's many problems with that. We need at a minimum, we need so much more, but we need disclosure laws and regulations. And because we don't have them, it takes a very, very long time to even understand what the impact of private equity investments in certain sectors is, right? So the nursing homes are a great example of that, because they started investing in the early 2000s, and there was a hearing in 2008 about PE-backed nursing homes, because there were these sort of anecdotal stories that were coming out that, there's problems happening in terms of quality of care in these nursing homes, but they were all anecdotal. And Charlene Harrington at UCSF, just your neighbor, really did a great job of trying to, through qualitative work, like illustrate those stories. Well, in a hearing, you have private equity folks that show up, or nursing home administrators who show up and say, there's a few bad actors, but that doesn't describe all of us. And then what do you do with that, right? Because it is just an anecdotal story. So it wasn't until just, post-COVID 2021, we get this, many of you probably know about this study, that was a big quantitative study of PE-backed nursing homes versus non-PE-backed. And they showed a relationship to the provider to patient ratios were much lower in PE-backed nursing homes, and that had an impact on mortality. So, it's hard to show an impact on mortality. That's a pretty major outcome, right? And they showed that. And so we did get we finally got some regulations around the ratio, but not around PE. So that's the other thing we're doing with private equity is we don't attack the problem of private equity. We put a Band-Aid on the problem they cause, like the Surprise Billing Act, right? No Surprise Bill and No Surprises Act, or a regulation around physician to patient ratios or provider to patient ratios in nursing homes. Because it's the power of the industry to fight against that. So.
Thank you so much. So I think that's all the time we have for today. I really appreciate you both coming and attending this and having this wonderful conversation. For folks who are interested, we are recording the event. We will be doing closed captioning and posting it to our website at healthpolicy.ucla.edu. You can also email us at healthpolicy@ucla.edu, and we can send you the links when they are available. Thank you so much to everyone for joining us today, and we'll see you at the next one.
And
Thanks
thank
so
you,
much,
Tiffany,
Tiffany.
for all the work putting this together. And of course, thank you, Colleen, for joining us. Quite a good crowd to come hear about your book, and really look forward to your next wave of work on the financialization of healthcare. Thank you.
Thanks so much, Mark, and thanks so much, Tiffany, and
Absolutely.
everybody who joined. I appreciate it. Take care, you guys.
Thank you.